Delhi IAP and Institute of Child Health, Sir Gangaram Hospital. I welcome you on this webinar on nephrology today. So for this important session, we have the eminent personalities with us, and I would be very proud to say that they are the dons of this particular subspecialty in pediatrics. So it's our pleasure to have Dr. Vasudev sir with us. So I would request Vasudev sir to take over from here and carry on with the proceedings. Over to Vasudev sir.
Thank you, Dr. Dhankar. Thank you very much. And it's a pleasure to be with all the friends. I think we all know each other very well. And
Sir,
Dr. Kanav is a very dear friend.
but for others benefit, please introduce sir, our chairperson, moderators
Okay.
session, sir.
Right. So I'm Dr. A.S. Vasudev. I'm a pediatric nephrologist consultant at Indraprastha Apollo and Max Hospital in Delhi. And with us, we have Dr. Kanav Anand, who is a senior consultant in Sir Gangaram Hospital in the Department of Pediatric Nephrology and a very eminent pediatric nephrologist of the country. And then we have with us Dr. Prashant Karia from Surat. He is again a very eminent pediatrician in not only Surat but Gujarat, and also the current ED member of the Central IAP from Gujarat state. And with us, we have our youngsters. Kanav, would you like to introduce the PGs who are going to present?
Yeah.
And Dr. Mukesh Dhankar, we all know, is the current Secretary of Secretary General of Indian Academy of Pediatrics, Delhi State, and again a very eminent hemato-oncologist based at Kalavati Saran Children Hospital. And he's been doing excellent work for the Academy. And welcome Dr. Alok Bhandari. Dr. Alok Bhandari has also joined us. He is the current sitting president of the Indian Academy of Pediatrics, Delhi State. And again, very efficient and very hardworking president, and he's holding multiple, he's wearing multiple hats also as the president of the Delhi Medical Association and so many other organizations he is holding on. So welcome Dr. Bhandari to the main show today of the Academy and the series of PG clinics. And over to Dr. Kanav for introducing your PGs and the subject of the day.
No, sir, before that, we would request Dr. Prashant to say a few words and Dr. Alok, sir, to say a few words, sir.
Yeah, please.
Sorry to
please. Yeah, please.
Dr. Prashant, sir.
Dr. Prashant Karia.
So thank you so much to IAP Delhi, and thank you especially to Dr. Alok and Dr. Mukesh. It's a privilege to be a chairperson when Dr. A.S. Vasudev and Kanav Anand both are the experts in the field of nephrology. I'm just a general pediatrician, going to learn a lot from them. And once again, thank you. And over to Alok Bhandari, sir.
Well, good evening, friends. I think our so many people are here on the line waiting for the session to start. We should not come in between science, academics, and our routine things. It's a great moment that our guest, Dr. Prashant Karia, is here from all the way from Surat, spared his time. And let's have academic session now, please. Okay.
Over to Vasudev, sir. Right, sir. Right, sir.
Right. So today's highlight for the case presentation is a child with recurrent UTI. So this is going to be the presentation, and initially it will be a case presentation followed by the review of the latest guidelines which have been published in May 2024 in the Pediatric Nephrology Journal, which is an updated version of the earlier guidelines of the Indian Academy of Pediatrics, which talks about what are the newer changes and nuances in the management of children with recurrent UTI. And the case will be presented by Dr. Kashish, who is a DNB trainee in pediatrics at Sir Gangaram Hospital in the Institute of Pediatrics. So over to you, Dr. Kashish.
Thank you, sir. Good evening, everyone. Myself, Dr. Kashish. I am first year DNB resident at Sir Gangaram Hospital. So today I am presenting a case of on recurrent UTI infection. So the patient details are a 14-month-old female child, informant is mother, date of admission was 16 May 2024 and date of examination was 20th May. Child presented with chief complaints of fever for 2 days, excessive crying during micturition, and increased frequency of urine for 2 days. History of present illness. The 14-month-old female child came to OPD, was apparently well 2 days back. She presented with a fever which was high grade, intermittent, associated with chills, relieved temporarily by medications. Child was active and accepting orally in interfebrile phase. Parents also complained of increased frequency of urination with diaper change, frequency of 12 to 15 times a day, normally which was around 6 to 7 times a day. Diaper was fully soaked. History of excessive crying during micturition is also present. Negative history. There is no history of cough or cold or rapid breathing or chest indrawing. No history of vomiting, abdominal pain, loose stools or constipation. There is no history of weight loss, decreased appetite or failure to thrive. No history of red color urine or edema. There is no history of dribbling of urine. There is no history of altered sensorium, seizures or weakness of limbs. Past history. At 2 months of age, child had first episode of UTI with symptoms of fever for which last for 3 days and excessive crying during micturition, for which they consulted local physician and he advised USG KUB that revealed bilateral hydronephrosis with horseshoe kidney. MCU findings later MCU done and the findings revealed bilateral grade 5 reflux with the medially directed calluses and malrotated kidneys. On urine, RM pus cells were present. Urine culture revealed E. coli. Similar episode occurred at 4 months of age, for which antibiotics given and child relieved. And child is not on any regular medications after that. DMSA scan done in August 2023 revealed bilateral malrotated kidneys and scarred kidneys with moderately impaired cortical function on right side. Coming to family history, she is the first-born child to non-consanguineous marriage. There is no history of similar complaints in family. About antenatal history, the mother's age at conception was 29 years, 30 years, and she conceives spontaneously after first year of marriage. In first trimester, pregnancy detected by urine pregnancy test. It was a booked case, no excessive vomiting, and dating scan was done, which was normal. Tablet folic acid, calcium, and TT was given during first trimester. In second trimester, quickening was felt at 5th month. Second dose of TT was taken in second trimester. In third trimester, at 8 months of POG, antenatal scan was done that revealed hydronephrosis, and amniotic fluid was adequate at the time. Natal history, placenta was normal in size. It was term delivery, born at 37 weeks, and the child born by LSCS. Birth weight was 2.5 kg, and she cried immediately after birth. No history of nursery admission, and child passed urine stools normally after birth. Socioeconomic history, the family belongs to upper middle class according to modified Goswami scale. Developmental history, all the milestones were appropriate till the age of child. Immunization history, immunized child is completely immunized till date as per national immunization schedule. Nutrition, child was exclusively breastfed till 6 months of age. Now the child is breastfed every 4 to 5 hourly along with complementary feeds. So the calorie deficit came out was around 12% deficit, and protein intake is adequate in child. So here's the brief summary that the 14-month-old female child first born to non-consanguineous marriage with history of fever for 2 days, increased frequency of urination, and excessive crying during micturition with history of 2 episodes of UTI in past. MCU done at 2 months of age, rescue of grade 5 VUR, and DMSA scan done at 5 months of age, rescue of bilateral scarred kidneys with moderately impaired cortical function on right side. Shall I continue, sir?
Yes, please continue.
Dr. Vasudev,
Thank you,
any questions on the history?
No, I think fairly clear. So let her continue with that.
Fine.
Okay, sir. Thank you, sir. General physical examination, general condition of child was good. She was alert, active, vitals were within normal limits. BP was measured in upper and lower limb, which was within normal limits. Weight of child is 11 kg, which is between 75th to 90th centile, and the length is 77 centimeter, which is between 50 to 75th centile. On head-to-toe examination, there is no pallor, interest, sinuses, clubbing, or lymphadenopathy was present. And eyes, ears, and hair examination was normal. In genitalia, there are no labial adhesions or cloacal malformation. Spine was normal, no dimpling or tuft of hairs were present. Limbs, in limbs there was no bony deformity. On per abdomen examination, the shape was normal, flanks appear normal, umbilical position is in center with no discharge. All the quadrants move equally with respiration. There were no visible pulsation. Skin over the abdomen was normal. Hernial orifice appeared normal, normal external genitalia, and there was no discharge. On palpation, abdomen feels soft on palpation, no tenderness present. Local temperature was normal, no organomegaly, and kidneys were not palpable. On percussion, resonant outward rod, auscultation, foul sounds were present. Respiratory system examination was chest was symmetrical in appearance, and no increasing work of breathing, retractions, or nasal flaring was present. Back examination was normal. Interscapular distance was bilaterally equal. No drooping of shoulder or winging of scapula was there. And on auscultation, bilateral air entry was equal. Normal vesicular sounds was present. Serious examination was also normal. On CNS examination, child was conscious, alert, and active. There was no cranial nerve abnormalities. Tone in both upper and lower limbs were normal. Bilateral jerk was present. So these are the investigation we have done in the hospital setting this time when
Just
child got
before
admitted.
1 minute before you go to the investigations, let us see about the examination part. And
Yes, sir.
Dr. Karya or Dr. Kanap, anything? I just want to know why did you examine the back and what is the importance of examining the back in such a child with this history and probable diagnosis?
Yes, in case of certain neurogenic abnormalities like myelomeningocele, leptomyelomeningocele, these are associated with neurogenic bladder. So spinal examination is necessary for that.
Right.
Anything else?
Um,
So one was to look for any bulges in the spinal area, that is the meningomyelocele. Two, you can also have you can also see scars. Maybe this child has already been operated, and what you see is a scar or a tuft of hair. Again, giving you telltale signs about the spinal anomaly. Okay.
yes,
Again, as you rightly told, that it may be associated with your neurogenic bladder.
neurogenic.
Fine.
Yes.
So that's the importance that there's a lesson for all our pediatric friends that whenever they have child with recurrent UTI, apart from the general examination, do not forget to see the back of the child because sometimes the telltale signs are there and we may miss if we have not seen. And did you examine the genitalia in this child?
Yes, sir. Genitalia was normal, sir. There was no
So
abnormalities.
what abnormalities do you expect in genitalia which can be cause of the recurrent UTI in these children?
Sir, if there is dribbling of, if there is any cloacal malformation present, sir, you can see that. Or if there is any,
Boys में बताओ, boys में क्या, what can be the genital problem which can
sir,
be
hypospadias can present more or less.
or right
Or
or
sir, the
Common चीज क्या है?
epispadias,
What is more common?
sir, phimosis, sir.
Yeah.
yes.
So phimosis and that too critical phimosis, especially in scenarios where you have ballooning of perpuse while passing urine. So that is what
Yes.
you'll have to look for. And also you have to comment on the genital hygiene. Sometimes the hygiene is very poor, so that may actually cause a UTI, and at time it may give you a false report of an you can say contamination of the urinary sample because of that
Yes.
debris that is there in the perpuse. That's why the concept of doing circumcision in children with recurrent UTI has come up because of the
Yes.
genital poor hygiene or the critical phimosis they are slightly predisposed to develop UTIs, it may also cause, you can say, obstruction at the level of the urethral orifice. Okay, so that
Yes.
obstruction can cause a back pressure change. Ultrasound will show, like you can say, the trabeculated bladder and hydronephrosis. So even that can cause it.
And in
Yes.
girls, what would you look for in genitals in girls?
Sorry, sir.
That in girls, what are the things which you would look for in the genitals in a girl?
Well, a hint is
Sir,
equivalent to phimosis. So what's the female counterpart of phimosis?
so adhesions and labial adhesions.
Yes, that is what you should always see in a child
Yes.
with the recurrent UTI, and they are often missed because nobody sees the child's genitalia, and they are often missed. And when they come with recurrent UTI for investigations on the table on radiology during MCU, we see that the child has labial adhesions, and that is the cause. So both the things in genitals, boys and girls, they should be mentioned, right?
And
Okay,
Yes.
please.
and one tip for the pediatricians, whosoever listening, so make sure that you open the labia and see what's inside. Because most of the time we see from externally everything looks fine, that's fine, but then try to open and see. Because at time you may find labial adhesion, and at time you may have fecal matter inside the labial area also. That means there is a cross contamination or fomite contamination. The parents just clean the genital area of the stools, and the way they clean it from back to front, so that leads to the genital soiling or of the by the fecal matter, which again leads to UTI.
Right. Please go ahead.
Yeah.
Thank you,
So
sir.
Kashish, did
Yes.
you have a look at the perianal area also? Any specific thing that you will comment on the perianal area?
So for
I mean,
any
what's
fissures or
yeah, the fissures tell you about your background history of maybe you can say
constipation.
constipation. That
Okay.
is linked up with your bladder bowel dysfunction leading to
Yes.
recurrent UTIs. Anything else?
Mm. And
There may be
so,
fecal soiling, which is an equivalent to encoparesis. So, in case fecal
yes.
soiling is there, so again telling you that may, because that can also lead to a lot of contamination. But encoparesis usually comes are more in the older age group children, not at this age
Yes.
group. But then that is what you are supposed to look. Thirdly, you can look for any patulous anus. So, patulous anus again tells you about your telltale signs about neurogenic bladder. Okay,
Okay, sir.
fine.
Thank you, sir. So the blood
So,
investigations. Yes, sir.
yeah, you can continue.
Okay. So hemoglobin was 11.4. TLC count at the time of like admission around 16, 17 of May. It was 21,000. Platelet count was 2.4 lakh. On in RFT, creat was 0.54. Sodium potassium was within normal limits. Chloride and bicarbonate was 108 and 18 millimole per liter. On urine RM examination, pH was 6, protein, nitrite, and glucose was within normal limits. There 127 cells were present and 4 RBCs were present on urine RM. Then we sent a specimen for urine culture, which showed Enterococcus faecium, and colony count was 10 to about 5 organisms per ml, and it was sensitive to teicoplanin and vancomycin. So initially, when child got admitted, then we started the empirical antibiotics injection, cefotaxime. And after the reports of the urine culture has come, after that we started the injection teicoplanin. And after that, child got relieved after 4 5 days and shifted on oral antibiotics. The fever
Fine. So I'll just
spikes.
like to stop you there.
Yes.
First thing is, in case you have started cefotaxime, as you said, I
Yes.
shifted over to teicoplanin. So there was a
Yes.
need to do it. Like, do you do it for all the patients, or in this patient,
No,
why
sir.
specifically it was shifted? Yeah, tell me.
Sir, if the child initially we should start on the empirical antibiotics only, and if the child is responding to the empirical antibiotics and fever spikes got relieved after 24 to 48 hours, then we need not to shift, like go to the antibiotics based on the sensitivity report. But if the persistent fever spikes are there or any complicating factors are there, then we should start antibiotics as per
So fine.
the
So
culture report.
so in this child, the child was spiking high grade fever and did not show
Yes, sir.
any response to the empirical antibiotic. That is the reason why it
Yes.
was shifted
Yes.
over. And
Yes.
after shifting, there was a significant like you can say, the improvement. Within 24 to 48 hours, the fever spike came down. Yeah, one is that.
Yes.
Second
Yes.
question is, as you said, there are pus cells are 127. So
Yes,
does
sir.
all pus cells suggest that it's a UTI, or there are other reasons also for pus cells in the urine?
Sir, apart from pus cells, their symptoms of UTI should to define the definition of
No, no,
UTI
no.
is the
The question,
symptoms.
question is not this. Question is, there is pyuria. So
Yes,
every
sir.
time you see pus cells in the urine, it means that the child has UTI, or
No,
there can be other reasons also where there is pyuria but not
no,
UTI.
no, sir. In certain other conditions, also WBCs can be present, like in glomerulonephritis, renal stones, or in case of renal TB and schistosomiasis, also in Kawasaki disease, also pus cells can present.
Fine. So basically, all your nephritis, whether initial nephritis,
Yes,
glomerular nephritis, can cause pus cells, lupus nephritis and pus cells. Stone disease, whether it's a stone disease or maybe just a crystaluria, hypercalciuria, hyperoxaluria, can still have pus cells.
yes,
If you have stents in situ, a child has already been operated in the stents, you can continue to have pus cells, but that does not mean the child has UTI unless he's symptomatic. And lastly, if you take samples from a catheterized patient, like he's already catheterized, and you take sample
yes,
because of the catheter, also you can have some kind of pus cells coming in there. So every pus cell is not UTI. So that is what the message is.
yes,
Fine.
yes.
And in the test, you have also said nitrite is positive and because leukocyte estrase is not. So what is the significance of nitrite test?
So as per recent guidelines, they have suggested the nitrite test and the leukocyte estrase test included in the dipstick test. Their sensitivity is good, so they can be used for the screening of UTI. If they are positive, then we can go for culture, and if the dipstick test is negative, then uh, an empirical antibiotic should not be started, and we should wait for the culture results.
Fine. So what does nitrite suggest?
Nitrite suggests the conversion of nitrate into nitrites. The bacteria in the bladder, they convert the nitrate into nitrites. So it means
Uh,
the
Fine. So
nitrate
it means there's
reduction.
fine. So it is that is the, basically it's a, the bug is having nitrate reductase enzymes which converts nitrate to nitrite. So that just suggests that is suggestive that there's an actively growing bug in the urine.
Yes.
Only false negatives you may get is if you do not have a bug which makes nitrate reductase. So that can be there. And what is the significance of leukocyte estrase? Because nowadays we talk about rapid diagnostic tests. Means child has come into the OPD. I don't have time for the culture report to come in. I want to be sure about the fact whether I'm dealing with a UTI or not because the child has fever. So I can do a rapid dipstick test in my OPD. So
Yes.
leukocyte estrase positive means what?
So the pus cells are present like neutrophils. They have the enzyme esterase.
Fine.
So
So basically, leukocyte estrase is a surrogate marker of pyuria. So whatever you see in the
yes.
urine routine report that pyuria in the microscope, so that can be picked up by leukocyte estrase. Nitrite positive means that there's actively growing bug. So a symptomatic child with leukocyte estrase positive, nitrite positive, that means the child is most probably having a UTI, and the pickup rate is as high as 90 to 95%. So you are more sure that this is UTI, and then you can start an empirical antibiotic. If it is negative and child is also not having any kind of urinary symptoms, then you can hold on for your culture reports and the routine reports to come down. So, Dr. Prashant, you want to add
Yes.
on something?
So fine, that is what we wanted to say, that nowadays we do have a deep tests which are available, which you will be, I think, be talking while we will be talking about the latest update. I mean,
Yes.
Kashish, I just want to ask you, when will this urine report, which is there, will be a false positive or false negative? Say, for example, a child is having a UTI, still the urine report will be negative, and if the child is not having UTI, still the report will be positive. What are the conditions?
False negative dipstick test you're asking, sir.
I'm talking about a urine routine because you have done a urine
Will
routine at present. So when will be the urine routine falsely positive and when will be the urine routine falsely negative?
The falsely positive can be seen in cases of glomerulonephritis, in case of renal stones, or in case of renal TB and catheterized sample, as Karan sir has told. The
Mostly due
cells can be
to
present.
contamination. Many a times it is due to a contamination. False
Yes.
positive. Yeah. And negative?
The false negative.
It's been said that the urine should be immediately actually sent for a reporting within
Freshly.
an hour. It should be done. It should not be refrigerated and kept for a 4 hours, 5 hours, and then checked.
Yes.
Because in that
Yes.
case, even if the UTI is there, it will be a false negative. Second
Yes.
thing you said about urine culture, 10 raised to 5 organism. What are the two things you will ask while you are having this report of urine culture or 10 raised to 5 organisms per ml, any organisms? Two things you will ask. Which sample is this?
Yes.
And how will you collect this?
Yes.
Kashish, you want to tell about things like what is what are the ways of collecting the sample and what is the significant colony
Yes,
count?
sir. Yes, sir. So there are three methods of collecting the sample. First is suprapubic catheterization, or by the Foley's catheter, or third by the clean catch sample. In toilet trained children, we usually collect the midstream clean catch sample, and
So what is
in case
significant
of
in that? If it's a clean catch sample, how what is significant colony count?
a significant colony count is more than 10 to power 4 to 10 to power 5
Fine.
cells per
So this is
ml.
something which is now for the residents who are listening, this is something new. The earlier guidelines used to say 10 power 5. Current guidelines says even 10 to power 4 to 5 is significant if it is a child with symptoms. So 4 is also significant. Fine. And how about
Yes.
catheterized sample? Whether you do
In
it with a
catheterized,
maybe
in
infant feeding
catheter,
tube or you do it with a Foley. Yeah.
yes, significant count is more than 10 to power 5 in case of catheterized sample, and sorry, 10 to power 4 in catheterized sample, and in suprapubic aspiration more than 10 to power 3 colonies per
Fine.
ml.
So again,
Yes.
this is also new because for suprapubic aspiration, earlier it was any colonies is significant. Now the current guideline says if it is more than 10 power 3, it is significant because there is still a risk of contamination. Right? So do you do suprapubic for all the patients or there's specific gentry of patients where you do suprapubic?
No, sir. We in non-toilet trained children also. First, we should try for the clean cat sample, and if it is not possible, then we should try the suprapubic catheterization or Foley's catheterization. And in infants, like sick infants less than 6 months of age, we should go for suprapubic catheterization.
Fine. So kids who are passing urine more frequently, you don't want to catheterize, already admitted child, sick child, and you also may be having a baby all admitted, so you have ultrasound guidance is there. So there you can do a suprapubic. But majority of the time it's a clean catch. In case parent is unable to take it, then in a OPD basis, you can just put a infant feeding tube, collect the sample and give it. Yeah.
Yes, sir.
One last question, Kashish. Your urine
Yes,
culture
sir.
is showing enterococcus.
Yes,
Suppose
sir.
it is enterococcus with candida. Two organisms are there. Then what will you
Yes,
do?
sir. So we should add antifungals. Uh,
Two organisms is the key.
Yeah. So two organisms discard this.
Candida
Two organisms
with
discard
contamination.
actually.
Oh, yes, yes, sir.
Yeah.
See, the newer guideline says if you are having a two organisms, discard the report because usually it is due to a single organism only, not due to the two organisms together. So that means there are more chances of a contamination. You can't treat with antibiotics, you can't treat with antifungal, you have to repeat it, right, Kana?
Yeah,
Yes,
sure. So basically just repeat the sample again. And in case you still doubt a fungal infection, you can just clean the genitals and send off a urine for a KOH or a fungal stain. So that will tell you whether the fungus is there or not. Fungus in general, remember, it's not a routine thing that you get a fungal UTI. It's more common in kids where they're already catheterized or they are having recurrent back-to-back UTIs where there is no break in between. So if there's no break in between because of the recurrent use of the antibiotics, then the fungal UTI actually comes in, or we are dealing with an immunocompromised host where fungal comes in. Otherwise, majority of the time, fungal UTIs are actually like whatever you see the fungal elements or a yeast in the urine routine is all contaminant.
I'll give you an
Yes.
example. I recently had a child who was nephrotic, and the child had edema of labial edema also. It's a girl child. And the culture was sent midstream, clean catch culture was sent, and it came out as Pseudomonas positive and Candida positive. So I said, I will not buy this report. And I told the resident that please look at the genitals. And the genitals were already having a lot of Candida around in their labial folds. And it was the urine which was collected in the bottle was touching the whole of the skin and then coming into the bottle, which was showing a contamination. So at times we have to examine the child. There may be a fungus present externally, which is being collected in the urine bottle if it has not been cleaned well. So all these precautions, and whenever there are two organisms, don't buy that straight away. As Dr. Kanav said, that you may need to repeat a culture before you embark on escalating the antibiotics. Right. Thank you.
Thank you, sir. Shall we continue, sir?
Yeah. So I think I just want to add on, as Dr. Kare was asking, what is the significance of colony count? I just like to add on, also ask the parent whether before taking the sample, whether the child has taken a dose of antibiotic or not. If you have already taken a dose of antibiotic, your colony counts may actually go down. So if you say, okay, the child is 10 power 3 instead of 10 power 5, but he says, I've already taken a dose of antibiotic. So that may be the reason why the colony count has actually come down.
Yes.
Secondly, if the child is passing a lot of urine and is a dilute urine, like if the child is on diuretics or has polyuria, again the colony count will be low, but they may be significant.
So
Yes, sir.
you can continue, Kashish.
Thank you, sir. So these are the images of MCU, which was done when the child was 2 months of age. So it is showing the dilated ureters on both the side, uh, depicting the grade 5 VUR. And in this image also, there is a dilated ureters of the.
Kashish, can you go back on the image? MCU?
Yes,
So I'll just like
this,
to, yeah.
this one, sir.
So I'll just like to, yeah, that's fine. So I'll just like to comment here on the MCU findings. So basically, what we see here is a huge bladder. Normally, we don't find such a like you can say large bladder. It's almost going up till the level of the umbilicus of the child. Fine. So again, it's not just a reflux. What we see here is a large bladder. The bladder outlet seems to be fine. There's no bladder outlet obstruction per se. Usually what you see is like two kidneys on two sides as normally what is seen, okay, and the reflux going up. But here we see the kidneys are almost kissing each other, okay, they're almost near each other. So this is a usual finding when you have a malrotated kidneys or a horseshoe kidney with a reflux, okay, or a cross-fused ectopic kidney, because otherwise the gap between the two kidneys is significant, but here it's almost touching each other. So can you go to the next image? So in the first image, what we see, this is called as a plain film, where the MCU has not yet started, the first image. Okay. So this is also significant because here what you see is the spine. So anytime you see that the spina bifida or you can say the sacral, some of the elements are missing. That is like a caudal regression syndrome, or the sacrum is not formed, the coccyx is not formed. So these are telltale signs that the child may be having a neurogenic element like a neurogenic bladder kind of scenario. In the second image, you see the bladder is huge. And in the third image is the post-void image. After the child has passed urine, still you see a lot of dye in the bladder and in the ureters as well as in the pelvis, suggesting there is a significant post-void residue. And this is one of the major reasons why children with reflux develop recurrent UTIs, because the bladder does not get completely emptied out. Hence, the need for uroprophylaxis comes in. Dr. Vasudev, you want to add on to the MCU? That's okay.
Right, I think it's good because you have seen
Fine.
the films practically, and also the ultrasound would have given some clue of
True.
whether the kidneys were horseshoe or they were ectopic. But yes, you have pointed out that the bladder is fairly full even after the urine has been passed, which is significant finding, and it should not be missed. Right, thank
So
you.
in these, sorry. So in these children, we actually ask them, like if they are toilet trained, we ask them for double voiding. Means they sit on the pot, they pass urine once, wait for another, say around 30 seconds to 1 minute or 2 minutes, and wait for the second contraction to occur so that whatever leftover urine is there in the bladder, that is also voided. Secondly, in that plain film, in the first one that you can see, is it's also fecal loaded. There are a lot of fecal matter as well as gas. So this gives you clues about associated bladder bowel dysfunction, and because of which the child can also have recurrent UTIs. So in case the child is constipated, you need to treat that as well. Because unless you treat it well, this can be another reason for recurrent UTIs, the bladder bowel dysfunction. So so MCU gives you a lot of clues, just not the reflux as well as the bladder. It also tells you about your spine, the the fecal loading. So all those elements are also told. And in case it's a CKD kind of a patient who is already have a, you can say the renal dysfunction is there, the GFR is low, you can also comment upon the bone health, that is CKD MBDs, chronic kidney disease, mineral bone disease. That is the evidence of any rickets if it is there. So plain film also you need to comment. So this is a tip for your the residents who are listening, that if you start commenting on these elements also, definitely it fetches you more marks in your exams. You can continue, Kashish.
So this is the DMSA film of DMSA scan showing the lower poles are like united lower poles suggestive of horseshoe kidneys, and the uptake in the left side is 73% and right side is around 26% as per the DMSA reports.
Fine, you can go back in to the previous image. So basically, whenever you have a horseshoe kidney, now you don't say right kidney and left kidney. You say right moiety and the left moiety, and you also have to comment on the isthmus, that is the joining part. So in a DMSA, the all the black areas that you see, the totally black areas, is the functional areas. The gray zones are semi-functional areas, and all whiteouts are actually the scarred area, or which we call as chronic pyelonephritis scarring. So if it is a photopenic defect, means there's just a small gray zone in between, where it's not totally white out. Okay, so that is suggestive of acute pyelonephritis. If it is totally washed off, then it's called as, you can say there's loss of cortical volume. Then it is something like a scarred kidney. And the more black it is, the better it's a function. So that's why the left kidney, which is appearing more black, has a better function compared to your right counterpart or the right moiety, okay, which is having less function. So what is the ideal time to do a DMSA after UTI?
The DMSA should be done after 3 to 6 months of the last UTI episode. Um,
So what happens if I do my DMSA maybe just after the UTI has been treated?
Uh, so because in case of pyelonephritis also like DMSs can have reduced uptake, so it can't differentiate between the scarred areas and the uh, acutely infected kidney.
Fine. So if you go back into too much of detail, so any photopenic defect is suggestive of acute pyelonephritis. Loss of
Yes, yes.
cortical volume is suggestive of chronic pyelonephritis or scar. So on a longer run, what we are more interested is as a part of workup is, on a longer run, we want how much is the scarred kidney, because that is the total loss of function that we have got. So that's why preferably the DMSA is done after 3 months. After 3 months, so that whatever acute pyelonephritis that has settled down, at times you may have a 100% settlement that there was a pyelonephritis, you can say a lesion or a photopenic defect, which has 100% become better. At time it may be a 50% improvement. At time there is no improvement also. So on the long run, what is more important is whether you have total loss of function or a chronic pyelonephritis or scarred area. That's why we avoid doing DMSA in an acute phase. But at sometime what happens is you may have high grade fever and the pediatrician is puzzled. Like, am I dealing with the renal abscess? Am I dealing with ultrasound is not showing anything. So if he wants to pick up a acute pyelonephritis, then DMSA can be done. But if you're interested in long-term damage, then what we do is a DMSA scan after say around 3 to 4 months, so that we pick up a chronic pyelonephritis.
Okay, Kanav, could you please take up some of the questions in the Q&A section? There are whole lot of questions in the Q&A section.
Fine. So can you finish the case and
Dr.
then we take up?
Gaurav yeah, sure.
Yeah.
Sure.
We're just finishing the case and then before the discussion we'll take up that. Yeah. So Kashish, you can go to the next one.
Yes.
Yeah.
So, sir, on basis of the history, physical examination, and the investigations we have done, my diagnosis is recurrent UTI infection with bilateral grade 5 VUR with horseshoe kidney.
With pyelonephritis, bilateral
With
pyelonephritis.
pyelonephritis.
Yeah. Fine.
So Kashish, what
So
is
done with
your
your
I think she has come to the diagnosis, and would you talk about the treatment part now, or we can just the plan of management? Kashish, before you go on, I think plan of management. What would you like to do now, taking step by step, 1, 2, 3?
Sir, yes, sir. If a child come with like fever for more than 48 hours or any symptoms suggestive of urinary tract infection like increasing frequency, urgency, burning micturition, or in like a child less than 2 years of age, um, they can present with fever, vomiting, diarrhea also. So in these cases, first we have to go for the screening test. So as per new guidelines, we should go for dipstick test that include the nitrite test and leukocyte esterase test. And if it comes positive, then like side by side, we have to send samples for urine culture also. And if dipstick test is positive, then we should start empirical antibiotics uh, based on the dipstick test, and we can change antibiotics after the culture sensitivity report if child is not responding to the empirical antibiotics, or if the dipstick test is negative, and uh, then we should wait for the results of culture, and after that we should start antibiotics.
No, what antibiotics we have already started. I said that after you have made the diagnosis of recurrent UTI with bilateral grade 5 VUR with horseshoe kidney, what is the plan of management you are going to discuss with the parents, that what next you want to do? You have done all the investigation, you have come to a diagnosis. So what would be the plan of management which you would counsel the parents for?
Yes, as this child has the third episode of UTI and also having history of horseshoe kidney, and the DMSA scan and is also showing there is a scarring in kidney. So we can plan for surgical management also. If first we have to start the prophylactic antibiotics. If child will not respond to prophylaxis and again have the episodes of UTI, then we should consider the surgical management, including the ureteric reimplantation.
So anything you want to continue with the case before we go on to the Q&A question answers or something?
So she has also prepared a review. So maybe we can just do not wait because majority of the things we already discussed. So maybe we can take the questions.
Right. Would you like to highlight the current guidelines, any changes which you had not covered right now? Like you have already told about the dipsticks and you have told about the cultures and about the antibiotics. So
yes, sir.
before we, any other points which you would like to highlight which have been, which are coming? Kanav, you want to take up the current guidelines before the Q&A?
So basically, the major highlights here is one is the all those things that we already discussed. Other than that is like initially it was any child was born with hydronephrosis, antenatal hydronephrosis. So the recommendation was start them on neuroprophylaxis till the time they do not undergo the complete battery of investigation, and we come to a conclusion as to what is the cause of hydronephrosis, whether it's a PUJ obstruction, VUJ obstruction, or a reflux. So current recommendation says do not start on prophylaxis till the time you have, like if you have not evaluated, don't start on prophylaxis. Prophylaxis are to be given only to children with recurrent UTIs. Otherwise, not recommended in general. If you have a low grade reflux, grade 1, 2, no need for antibiotic prophylaxis. 3 will be that the duration of antibiotics for UTIs actually come down. So if you are dealing with a pure cystitis like scenario or lower urinary tract involvement, upper tract is fine. A short course of antibiotic of 3 to 5 days is also good enough. In case you're dealing with UTI or upper tract involvement, then the antibiotic have been stepped down to around 7 to 10 days, vis-a-vis it was 10 to 14 days earlier. So these are the major changes that have actually come into the newer guidelines.
And I think we have also shortened the course of antibiotics. If we are
Antibiotics.
starting
Yes,
with
sir.
IV antibiotics, then we can continue for a couple of days, 2, 3 days. If the fever has remitted, we can switch to oral antibiotics. And in children who are not very sick, we can start with oral antibiotics instead of starting with IV antibiotics. And again, shortening the course of antibiotics from 14 days to 10 days, and from 10 days to 7 days, and 7 days to 5 days. So depending upon the type of UTI and recurrences of UTI. So shorter
It's like,
courses, more of oral antibiotics, less of IV antibiotics, and the switch over from IV to oral as soon as the child is well.
and second thing is in terms of evaluation. So earlier it was child less than 1 year. If you have a recurrent UTI, like if you have a first episode UTI, you're supposed to do DMSA, MCU, everything. So now it is you just do an ultrasound. If your ultrasound shows some abnormality, then definitely you need to go in for your battery of tests, that is DMSA and MCU. But if your ultrasound is normal in the first episode UTI, you can just stop it there. Do an MCU only if it is causing recurrent UTIs. Otherwise, not required.
I think you can take questions if, as
Question.
Dr. Nupam is saying, there are few
Fine.
questions.
Questions, yeah, fine. So coming to the first question, as asked by Dr. Gaurav, please discuss the bladder maturation reflex after birth and the bladder capacity. So Dr. Kashish, you want to talk about it?
So, bladder maturation reflects.
Yeah. So I'll just say that coming to the bladder part, so normally the child is born with a very small capacity bladder, and you do not have too much of, you can say, the neurological network, which comprises of the autonomic nervous system, the the local reflex, spinal reflex, and the CNS. It's not very well developed. Okay, so because of that, the child keeps on passing urine very frequently. Small capacity bladder and no neurological, you can say, control. So approximately a newborn may be passing urine almost as high as around 15 times per day. Fine. So as the age grows, there is maturation of the local neurological reflex to the bladder capacity also keeps rising. And by the time you're 5 year old, fine. So your bladder capacity increases and the urine frequency comes down to 3 to 8 times per day. So if your child after the age of 5 years passing urine less than 3 times a day, it's called as less voiding frequency. More than 8 times a day is called as increased voiding frequency. Secondly, comparing like the maturation part. So normally you become day, dry by day by around about 2.5 to 3 years, dry by night by around 4 years. Hence, the bedwetting actually you will say label the child as having enuresis only after the age of 5 years. So that is what happens. The bladder capacity formula. So when your child is born, the bladder capacity is almost like 2 ounces. 1 ounce is 30 ml. So it's like 60 ml. And then after that, your the formula that we use is age of the child in years plus 1, okay, in ounces. So if it is a 4 year old child, so 4 plus 1 is 5 ounces is your bladder capacity. So 5 into 30 is around about 150 ml. Okay, so it's age in years plus 1 in ounces is your bladder capacity. So this reaches the peak level by around about, you can say the adult value by around about 12 years. So by 12 years, the adult value is achieved, that is around about 400 ml. Fine. So next question is any antenatal significant finding in our case? So it was not there. Association of DSD with with urogenital malformation. So yes, DSDs definitely have associated urogenital malformation, but your recurrent UTI is going to come in if it is associated with anorectal malformation, and there are, like you can say, the child does not pass stools at all, or keeps on having encoparesis, so definitely UTI chances increase, especially if it is more of a girl child. Or if there is a rectovesical fistula, the rectum is connected to the bladder. So again, because of that, you'll have recurrent UTIs. The next question was why third generation cephalosporin and not aminoglycoside? So normally, as a part of, you can say, if you want to start a antibiotic for a child empirically, so normally we say you can start with either coamoxiclav or you can use a third generation cephalosporin. Okay, as a first line. Aminoglycoside is usually restricted. We don't use it left and right because there may be a chance that the UTI may have affected the upper tract, that is the kidneys. So if the kidney is already damaged, the creatinine is going high, or it's a, you can say, a not a simple UTI, that is a complicated UTI where your kidney is affected. So aminoglycoside can add to the troubles. It may increase the serum creatinine. That's why we use a third generation cephalosporin or a coamoxiclav for a empirical therapy. If you want to use aminoglycoside because the culture has come positive, then definitely you can keep a tab on your serum creatinine values. Then another question again, Dr. Kashyap, you want to add role of repeat urine routine in a culture. So should we always repeat a urine culture after you've completed a course of antibiotic?
No, sir. Sir, when we start the empirical antibiotics, like IV antibiotics, and child won't respond within 48 hours, like clinical symptoms, fever, spikes, will be there, then we should go for like repeat RMR culture.
Fine. So normally it is said that repeat urine culture not required, but you can do a urine culture in case, like in a clinical scenario, the child started improving. Third day, fourth day, every fever came down, everything was fine. You're continuing your antibiotic, and then now again start spiking fever. So in those scenarios, when you doubt this is another repeated episode of UTI, or maybe the drug is not working, then maybe you can think about repeating a culture. Or as Dr. Prashant told, that you're dealing with a mixed growth. If it's a mixed growth, then definitely you need to clean the genitals and repeat a urine culture. Your urine routine repeat, yes, definitely it can be done. Maybe you started off with the pus cells for around 50. So before you stop your antibiotic, you just want to be sure that urine pus cells are coming down, everything is coming down, then maybe you can repeat a urine routine in between. Or if your urine routine was showing a lot of proteinuria also associated with the UTI, again telling you that there may be a hit to the kidney. So in those scenarios also you may repeat a urine routine. But in general, a routine culture every time you deal with like you have finished the course of antibiotics is not required. So next question was when to
Yeah, I
switch from
think this
IV.
should be very clear, all the pediatrician friends, that we should be very clear that we are not chasing the bacteria till the last bacteria, and we do not need to find out whether the culture is now 10 raised to the power of 3 or little more. Once the child is well and the child's fever has come down, symptoms are better, as Dr. Kanak said, you may repeat a urine routine, but don't go in for culture because for sure there may be a small amount number of bacteria which may show you only count of 10,000. Then again you are tempted to restart the antibiotic or prolong the antibiotic, which actually is not required. So don't go in for culture and don't get trapped.
Even if you don't want to start, your patient will keep on running from one doctor to other doctor that culture is still positive, what shall I do? Fine, so it's better do not get into the habit of repeating a urine culture. So the another question is when to shift from IV to oral, that Dr. Vasudev has already spoken. The moment child's general condition is better, the toxicity is better, you can shift from IV to oral. Then this Dr. Kashish can answer role of ultrasound in UTI.
Sir, ultrasound we should do in case of first in case of children less than 2 years of age and the organism is apart from E. coli, or in case of the recurrent UTI infection, we should the first investigation we should do is ultrasound. And if the age is less than 1 year, then we should do ultrasound, MCU, and DMSA scans. In children like age between 1 to 5 years, first we should ultrasound and MCU, and if ultrasound and DMSA scan, and if they are abnormal, then we should go for MCU. And children with age more than 5 years, ultrasound alone is okay. But if there is some significant abnormality on ultrasound, then we should go for DMSA scan. Yes.
Fine. So in general, just remember child coming with UTI and you have never done an ultrasound in the past, do an ultrasound. Ask specifically points in the ultrasound. Otherwise, it will be like kidneys are normal. So you have to ask for the kidney size. You have to ask for any pelvis dilatations, any ureteral dilatations, any structural anomalies of the kidney, any you can say a stone in the kidney or urolithiasis, or any development of a renal abscess. Comment on the bladder, the pre-void as well as the post-void, whether it's significant or not. So all these things need to be commented in the ultrasound. So if it's just a report which says kidneys are normal, it is of no use. The next question is, what is asymptomatic bacteria?
Sir, if a child is not having any symptoms of UTI, but on urine culture, the colony count is like significant colony count is present, then it is asymptomatic bacteria.
Fine. So
It should
significant colony count on the culture
plus
without any symptoms. Now the pyuria is plus minus. The pyuria may be there, may not be there. So some people may just talk, if your pyuria is not there, people may say it is just a contaminant. Okay. But whether pyuria is there or pyuria is not there, but child is asymptomatic, you need not treat it. Fine. So asymptomatic bacteria is very common in adolescent females and beyond. Okay. And it's like almost 2 to 3 times more commoner than in males. And you need not treat it. Only odd point where we start treating asymptomatic bacteria is children who have recently, you can say, had a kidney transplant. Okay, that is in the first 2 months of your kidney transplant, where your significant immunosuppression has been on. So there you treat. Second is if in case it's a pregnant lady. So these are the only two scenarios where we start treating asymptomatic bacteria. Otherwise, it need not be treated. Now, what's the difference between simple and complicated UTI?
is simple UTI is like fever with symptoms of UTI like burning, exudation, vomiting, diarrhea. Or complicated UTI means if there is any complicating factors like certain if renal anger tenderness is present, persistent vomiting, persistent diarrhea is like there, or or any bladder bowel dysfunction is present, or the infants, the first episode of UTI less than in a child less than 3 months of age is it as complicated
So basically, simple UTI means it's like non-toxic child, just comes with fever and maybe just a lower urinary tract symptoms. That is simple UTI. Complicated UTI is when you have a high-grade fever, toxic-looking child, dehydrated child, having renal angle tenderness, where you're thinking that the kidney may have got affected with a renal abscess or a pyelonephritis. That is complicated UTI. Earlier, we used to differentiate the two in terms of how to treat. So every complicated UTI used to receive IV antibiotics. Now the differentiation has gone off. It says if the child is non-toxic or the child is okay, taking orally and everything, so you can still start oral antibiotics. Now, what is recurrent UTI?
Sir, more than one episode of UTI in like any time period is considered as
Fine.
recurrent
So
UTI.
any second episode of UTI is recurrent UTI. Okay, so that is recurrent UTI. Then comes question is what is breakthrough UTI and indications of pyeloplasty? What is breakthrough UTI? Where do you specifically use the word breakthrough UTI? It may be that, so if your child is already on uroprophylaxis, okay, and on uroprophylaxis, he still develops a UTI. So that is called as breakthrough UTI. Now the next question was indications of pyeloplasty. So indication of pyeloplasty is for PUJ obstruction. So normally it is said if the pelvis size is more than 30 mm, if the differential kidney function is less than 35%, if the drop in kidney function in 2 consecutive DTPS is more than 10%. Okay, so these are the indications when you do a pyeloplasty for a child with PUJ obstruction. Fine. And DMSA we have already discussed, and then role of incidence of bladder bowel dysfunction in your practice. So, Dr. Vasudev, do you want to comment on it? Role of BBD in your practice?
Yeah, I think now this is becoming a very perpetual problem. And every alternate child we find constipation is there, whether they have UTIs or not. But constipation is becoming very rampant. And there's a very direct correlation between the children constipated children and recurrent UTI, and almost 30% of these children who have constipation will get recurrent UTI. So treating the constipation at times is not the solution, and we do not need to embark on other antibiotics and other things and just treat the constipation. Majority of these children with recurrent UTI may get better without even going in for further investigations and detailed investigations or IV antibiotics. So it's becoming very rampant, and we have to. Some of these children would require prophylaxis also if they have bowel bladder dysfunction. Apart from treating the constipation, we need to give them prophylaxis till they are totally out of wounds. Right? Anything more, Kanav?
Yeah. So almost you can say 60 to 70% of the kids with you can say reflux may have associated bladder bowel dysfunction. Only thing is how well do you get that information out of them? So if you say, okay, does your child have constipation? 80% of the children with constipation, the parents will say straight away no. So better is to show them the Bristol stool chart, ask them whether the stools are hard or not. That is something like Bristol chart 1, 2, 3. So if it is hard, then the chance of bladder bowel dysfunction is there. 2, you have to ask them about voiding disorders. Means the child is having bedwetting, or the child is passing urine more frequently, or the child is passing urine less frequently, or the child is having urge incontinence, hesitancy. So these children, this gives you a hint that the child may be having an associated bladder bowel dysfunction, or a simple encoparesis also gives you a hint about associated bladder bowel dysfunction. Remember, bladder bowel dysfunction itself is a cause of recurrent UTIs. Okay, so if you just treat the reflux by doing a surgery, it is not going to solve the problem. The patient will come back to you and say, I did the surgery as per your advice, but still my recurrent UTI continues. And if you do not treat your bladder bowel dysfunction well, the surgical outcomes after the reflux surgery is also very poor, because your bladder will continue to get compressed. It's a high pressure bladder. So even if you do a surgery, you can say the surgery may actually fail off. So you need to treat the bladder bowel dysfunction. To take help, you can use a bladder diary, which tells you about your maximum void volume, minimum void volume, and gives you interpretation whether the child is actually having a bladder bowel dysfunction or not. But you need to be looking out for a bladder bowel dysfunction rather than waiting for the parent to tell whether the constipation is there or whether the child is having voiding symptoms or not. Because he may actually come with recurrent UTI to you, or you can say ultrasound showing a hydronephrosis. Because even a bladder bowel dysfunction, because of the pressure dynamics, may cause the hydronephrosis without having a reflux.
I think I would suggest all my pediatric friends that whenever they have these difficult cases which are uncommon, let us have a joint shared care with a pediatric nephrologist along with a pediatrician, which will have a better outcome, and the patients also would benefit out of it.
So any other questions from anybody or any comments? Dr. Prashant, if you're there. Dr. Vasudev, can we close the session then? It's already 9.
So,
Post 9.
Dr. Anand and Dr. Kanav and Dr. Vasudev, only comment from my side, it's such an excellent discussion today. I think we have discussed UTI number of times before, but today's question answer session and clarity was very good. So congratulations to the whole team, and also thanks to Dr. Vasudev for being there, which makes the discussion very, very interesting. Thank you so much.
Thank
Thank
you
you,
very
Dr.
much.
Pankaj.
And
Yeah.
all the viewers and all the panelists, especially Dr. Karia, who joined us, especially from Surat. I don't see him around, but I think he might be busy. But it was a wonderful presentation, very, very clear. Under guidance of Dr. Pruthi and Dr. Kanav, the student has to prepare it so well. I've been their examiner so often, so I know the quality of presentations which both of them ensure. Thank you very much, and it was a pleasure being here. Thank you.
Thanks. I'd like to thank Dr.
Thank you.
Kashish as well, because being a first year resident, presenting it to this level is good. So thank you, Dr.
Thank you, sir.
Kashish, and all the viewers.
Thank you,
Yeah.
sir.
Thank you very much.
Thank you, sir. Good night.
Thank you. Good night.
Thank
Jai
you very
Hind,
much,
Jai Hind.
everybody. And